At MedStory, we take privacy seriously and follow all healthcare privacy laws. Some details may have changed to protect confidentiality. The views expressed are solely of the individual speaking and do not represent the views of their employer.
Follow the rules as long as you need to until you can become the person that can change them. And I want to be the person that can change the rules that don't make sense right now.
I love that so much. Heck yeah. Welcome to the MedStory podcast, where we share the stories of the greatest minds in science and medicine. I'm Spencer Luck, and today's guest didn't show up dreaming of becoming a doctor. And she didn't follow the predictable path or have family of physicians. But what she discovered between the lab bench and the clinic changed everything. Dr. Ariela Marshall is a hematologist, educator, and an advocate whose journey shows what happens when curiosity meets courage. Like many of us, she thought medicine was about fixing people. What she didn't expect was that it would also change her fix for the system itself. In her early rotations, she saw moments that tested her, not medically, but morally. A patient who died overnight, and no one even mentioned it. A culture that prioritized endurance over empathy. And as a young woman in medicine, she faced bias head-on. Comments that weren't malicious, but were blind in their weight. Those experiences became the foundation for her life's work, creating a more human and equitable healthcare system. So from Harvard to Penn to the Mayo Clinic, and through infertility, advocacy, and self-discovery, Dr. Marshall's story is proof that transformation in medicine starts from within. And that, my friends, is where our story really begins. Let's go back to first when you were a little girl. And at what point did you know that you wanted to become a doctor?
That would be a long time after I was a little kid. So I am not one of those kids who is running around at age 6 saying they want to be a doctor. I went through a iteration. I wanted to be a vet. I think then I wanted to be like an interior designer and architect. And I actually went to college thinking I was going to be an economics major. So all over the place. And even when at the end of my first year of college, I decided to be a biochem major, I wasn't sure what I wanted to do with it. And so I then tried to get experience in the different areas. I was in a lab for a while. I started shadowing doctors. And so I wouldn't say it's probably until or maybe junior year of college that I actually decided that I wanted to go into medicine.
Okay. And at this point, where were you going to college?
I was at Harvard for undergrad.
Okay. And so do you remember a moment while you're in undergrad or what your thought process was where you're like, maybe I do want to go to medical school?
Yeah, I think my abilities were in the sciences. And so I think after I started off as an economics major, it's like, not so much talent and ability here. Let's go to something I feel more comfortable with. Okay, I'm going to do the sciences. But then I think of the options available, you can work in a lab, get a PhD, be a lab scientist, you can work for a pharmaceutical company, you can do these different things. And I think I liked lab work from the let's learn things standpoint, but I didn't like it. Number one, because there wasn't a lot of human contact. But also number two, I feel like it was this long period to see your efforts come to fruition. So basically, you start this experiment, you can be working on a molecule for your lifetime. And maybe I'm just a really impatient person, but I want to see things happening in front of me. I want to see myself making a difference in real time. And so I think that is ultimately why I decided to go to medical school, because I like the spirit of inquiry, but I like doing things and seeing the effect right away.
Do you remember what you were doing or where you were when you started to come to this kind of realization?
I mean, I think it was a combination of working in a lab for a couple of summers and seeing that prolonged process and saying, wow, I'm not sure if I have the patience to do that. But then I also started working with an investigator. I started off as a clinical research assistant, but he would let me shadow him in the clinic. And I'm like, wow, he's doing this research and I'm taking part in that, and that's cool. But I can actually see what's going on in the clinic in real time and see. He was actually an oncologist, a cancer physician. And so you can see you're giving this chemotherapy and things shrink or things grow, and you're going to change the plan based on that. So I think that it was getting that real life experience of being, hey, this is the coolest part of what I'm watching, of the things that I try to, it's like, okay, I think that's more aligned with what I see myself doing.
Okay, got it. So you actually got to see him interacting with patients?
Exactly.
Was there any patient, do you remember any patient from that experience? Like any instances at all?
I mean, I'm not sure if I remember individual patients. I remember that it was my first time seeing things. Obviously, I'd been a patient, you go to your pediatrician and whatnot, but it was my first time kind of seeing things from the physician's perspective. And I think realizing that there's more to it than just prescribing medication, seeing what happens, seeing kind of all the social aspects of it. And it was cancer, so it's a really hard field. And so, I mean, it may not have been related to my personal journey, but I do remember some of those really tricky social situations, people that were unable to pay for their treatment or really having a hard time getting to the appointments. Or on the other side of things, I definitely remember this one guy, like 80, he was there with his wife. She was also 80. And I just remember him saying, she's still the most beautiful woman I've ever seen. And it's like, oh, you get to witness moments like that in real time. And so that's just such a privilege, I think.
I love that you're bringing that to the surface. I think oftentimes we can forget of all those magical moments that we get to experience on a day-to-day basis when working in healthcare. So that's a good inspiration to go into the field for sure. So at this point, you're doing your undergrad at Harvard and you say, you know what, I want to go to medical school. Did you start applying to a bunch of different schools? How did you decide where you wanted to go?
I did. And it was one of those kind of go straight through type of people. I never took a gap year or anything. But it was, I would say, challenging for me because maybe I didn't seek the guidance that I should have. I think like now being on a medical school admissions committee, I know exactly what they're looking for, but I didn't know that as an undergrad. It's like, okay, I'm just going to apply to medical school. I'm a biochem major. I've had some experience. I'll just apply. And so I applied and I got in a number of places. I actually got waitlisted at all of my top choice places, including Harvard Medical School. And so I had decided to go to a different medical school, and I actually went down there and got an apartment lined up with a lease signed and everything. And I was like all ready to go. And then sometime, I think like late July, early mid-August of that year, I got an email from Harvard Med School saying, hey, a spot has opened up on our wait list. Do you want to take it? I'm like, oh my God, yes. And that was one of the most experiences I had like early on in my medical career. And I often don't even remember that when people are like, where did you go to medical school? I'm like, oh, I was super lucky. I got in off the wait list. But that was a really, really nice start, I think, to that medical journey.
Where were you when you read that email?
I was actually in the apartment of the person that I was dating at that point.
Okay. And then, so you remember reading that email, and was there any thought of, I have to change course?
No, it was pretty because, I mean, it was in Boston. And so that's where I'd always hoped to go for medical school. So it was just like, oh my God, my dreams are coming true type of thing. I don't have to move. The person I was in Boston at that point, so I'm like, everything is working out. So there wasn't even, I guess the one hesitation was they hadn't said anything about financial aid yet. And so that's always been a big thing for me. I went to college there were some academic scholarships, but it's mostly need-based financial aid. I do not come from means whatsoever. And so I was like, oh my God, I really want to do this, but I really hope they come through financially. But they did. And so that was, like I said, there was really no question in my mind once I knew that they would give me the financial aid that I needed.
Tell me about your first day at Harvard Medical School.
I think I don't remember anything about the classes or the medical aspects of it. They have a few days where you just get to know your peers. And I think I realized going in that one of the big mistakes, but one of the things I hadn't really paid attention to in college was making friends. Actually, I'd been so focused on, let me get in there, let me do really well in my classes, even though I don't know what I'm going to do with my career early on. But got to get in there, get the A's, do really well. I didn't really focus on friendships. I did make friends because I was on the ballroom dance team. It's like a big extracurricular activity. It took hours of my time. And so I made friends based on people I was interacting with in that setting, but I didn't make any kind of effort to make friends. And I think I came away from that with, gosh, I got to do a better job in medical school making friends. And I was like looking around myself, like, who can I make friends with? And the first person I made friends with was a girl I saw walking down the street, and she like tripped. Like, not a big thing, didn't fall, nothing, it was just like tripped. But then I saw her laugh to herself. And I was like, I want to be friends with somebody who can trip and laugh at themselves rather than get really frustrated or anything like that. And so that was the first person I introduced myself to, and we became really good friends.
Oh, that's amazing. Now, so you get in, you're going through school. Is there any moments that stick out in your head of where maybe you would consider the hardest time at this chapter of your life? Any of the big challenges, anything like that?
Yeah, I think because I had no doctors in my family, I didn't know anything about what medical school was all about, really. I didn't know a lot about the culture of medicine. I mean, as I said, I'd had those experiences shadowing, but that was it. So you're shadowing in clinic for a couple hours a week. I don't think you really get the culture of medicine. I did not get the hierarchical structure, just the pure fatigue aspect of training. And so I think first 2 years is basically classroom-based. Not easy, but it's not that different from college, so that was fine. But I think getting into the clinical third and fourth year, it did become really tough because I just was completely unaccustomed to that culture. It was very foreign to me. So I think of myself as an anthropologist. It was like exploring an entirely different culture. I'd never seen that before. I'd never seen people treat each other that way. I'd never seen people treat patients that way before. And it was just like, what did I get myself into? I mean, is this even the right path for me? I think, if you would ask for what's an example of that, my first rotation was a surgery rotation. And surgery rotation, you get there at 5 a.m, you do your pre-rounds, round with your team at 6 a.m, and then you get to the operating room and you're like, we're rounding with our team at 6 a.m. And I'm like, hey, like we skipped that patient's room. And they just stared at me and they're like, what are you talking about? And it turned the patient had died overnight. There's no acknowledgement of it. There was nothing. It was just like, oh, thank God it's one less person on our list. So rounds take less time today. And it's like, whoa, I just didn't know how to react to that. Okay, I guess we're just moving on. But it was, so things like that were just very foreign to me. And I think that was also where I first experienced kind of gender bias, which then informs a lot of what I do now in my work for gender equity for physicians. But it was just those first exposures to a lot of things that were very jarring for me.
What was your first exposure? What was the first moment when you realized that there may be some gender bias within the system?
It was not subtle. Again, it was in the operating room. So not at all to say that all these examples should come from surgery, but being a very male-dominated field still, I think there is more likelihood of it. And I just remember the person who's operating, you're rotating there as a med student. You're lucky if they even pay attention to you. Oh, what's your name? Like Ariela. Oh, like the Little Mermaid. And it's like, oh yeah, she was the hot one in the bikini, right? Do you ever think of that? And it was like, yeah, I had no idea, I mean, even how to respond to that. And it's just, I really highly doubt this person even gave a thought. I don't think they intended anything horrible by it, but just completely unaware that that is not at all appropriate to say to anyone, much less a medical student who has never been in the operating room before. But just things like that, or saying, hey, patients make comments all the time. Are you the nurse? Can you bring me my blanket? And nothing ill-intentioned. It's just that you wouldn't be getting that type of thing if you're a guy.
Yeah, that's true. That's true. So you are going through school. You're starting to realize this isn't the reality that I thought it was going to be, but yet still I'm in it. So I'm committed to it. So then what happened next? How did you decide what direction you wanted to go from there?
Yeah, so this has always been one of the things that I think back on as maybe I should have done differently in my career. So I'm a person who likes a plan. And I was like, oh gosh, like I said, should I even be here? Was this the right choice for me? But I made this choice. I'm going to come out of this. It was possible for me to go to med school because of financial aid, but I'm still going to come out of this with a lot of debt. So I better finish up and do a residency and go into practice because that's the only way I'm going to be able to pay off my debt. Oh, okay, you're here now. What are you going to do? You need a plan. Okay, I shadowed this oncologist and I thought it was an amazing experience. That was obviously before I saw the other side of things, but I thought back and it's like, that was amazing. I want to do that. And so even when I was entering medical school, I was like, here's the plan. You're going to be an oncologist. And what does that mean? You do an internal medicine residency, you do the hem-onc fellowship, and then you're an oncologist. So I actually never gave a chance to other specialties when I was rotating in third and fourth year. It was always just, this is what I'm going to do. So I wish, thinking back, and this is what I advise a lot of trainees to when students ask me, how do I pick a specialty? I wish that I'd given more chance to other specialties, not because I dislike the field that I chose, but because there's other things that may fit my personality better. So, for example, I told you at the beginning, I really like seeing things in real time. What I put in, I can immediately see what happens related to that. So perhaps I should have considered something like emergency medicine. Or if I had gotten over the gender bias aspect of it and the people telling me that you can't be a surgeon and mom, perhaps I should have considered something like trauma surgery. But, that's all hindsight now. And so I definitely went in there as like, what's the plan? You're going to be an oncologist. What do you need to do? Keep doing your research, get into a good medicine residency, and then get into a hem-onc fellowship.
Do you regret it?
I don't. I do and I don't. I think like the grass is always greener, right? So I look and I'm like, it could be, and we can talk later about, I love what I'm doing now because it's like the exact aspect of the type of work that I like in the field that I chose. But I think for a number of years after I finished fellowship, I was doing a mix of things. Some of them I liked, some of them I didn't. And so at that point, you always think, oh, it would be really nice if I had done emergency medicine and I could do my X number of shifts a month and be in on the action and see all the cool stuff and then just shut down after I'm done with my shift and go home because that's the type of person I am and that's what I like to do. And so there's part of me, oh, that would have been really cool. That's probably, wow, there's huge rates of burnout in emergency medicine. It's not always as good as it seems. That friend I told you about that I made in medical school, she's in emergency medicine and I've heard, about some of the big challenges. So I mean, you never know until you're there. So I can't say I regret it or don't. I think right now I'm really happy with where my career has turned out. But there was years of time period where I wasn't.
Wow. Yeah. I can imagine that's a really tough time. So you went and then you did it and you did your residency at UPenn?
I did.
Okay. And then and that was your residency was in everything, or were you specializing in oncology at that point?
Well, residency is like a broad training. Right. So you can't do an oncology residency. I mean, I did an internal medicine residency. And so when you do that residency, you can then do a fellowship in cardiology or infectious disease or hematology oncology like I did. So it was in medicine residency. So 3 years of kind of general medicine training, but no surgery, no OBGYN, nothing like that.
I will say, so I'm trained as a physical therapist and I've gotten to work on an oncology floor before, and it really opened my eyes to that field. And one of the coolest things that I did see about it, at least from an acute care perspective, is that this is probably the only department inside the hospital that can truly develop a relationship with their patient because they're there longer than the typical patient in a hospital. And I just felt that the team that makes up that oncology team was so different because they had that time to develop that relationship and the amount of empathy that they had to have on a daily basis, but at the same time, while maintaining their sanity, because it's a really challenging field to be in. And so when you're dealing with something like that, when you're dealing with people that are facing life-altering disease that's altering their life slowly, oftentimes, How do you handle that from a personal perspective?
That is a great question. I mean, I think I am actually a specialist in a non-oncology subset. So I went into a hematology oncology fellowship thinking that I was going to do breast cancer because I've always been interested in women's health. But when I got to fellowship, I actually started to do those hematology rotations, including inpatient. What we call classical or benign hematology was essentially non-cancer hematology, so bleeding and clotting disorders. And so that's what I actually chose to specialize in. And I will say it's not benign. We actually renamed it to classical hematology. It used to be called benign hematology, and it is not benign by any means. There's life-threatening blood loss, there's life-threatening bleeding. But what I do, it happens on a very quick and acute basis. And that is like the aspect of medicine that I love, actually. So all the way back to college, when I said, hey, I wanted to do a specialty in medicine, or I wanted to do medicine instead of lab research because I want to see the effect of what I'm doing right away. That's actually part of what I love about classical hematology as well, because on the inpatient side, you are dealing with life-threatening bleeding, life-threatening clotting, and it's a very acute and time-sensitive type of treatment. But that part of what you may be missing out in this area of the field is that you don't necessarily have those kind of long-term relationships like an oncologist would with their patients. So it's a very different type of relationship. I mean, it definitely works for me because I like to be on the action. I like that acute setting. What are we going to do with this like massive bleeding, or this person has a life-threatening clot in their lungs? What can we do about that? Or, hey, this person was on a blood thinner for their clot, but now they're bleeding. What are we going to? So I really like that aspect of it, but there are some aspects that you miss out on, and that's one of them.
So at what point, you did Harvard Medical School, you went and did your residency, you went and you did your fellowship, and then at what point, my understanding is you had some time at Mayo as well.
Yeah.
And tell me that.
That was right after fellowship. So that was my first kind of real job after finishing fellowship. So what had happened is that I met my husband when we were both training at Penn. So he was a few years ahead of me. So he was already a cardiology fellow when I was a general kind of internal medicine resident. So I then went to Boston for my fellowship. He finished up his training in cardiology, his fellowship at Penn, and then he actually got a faculty position at Mayo. He had done his residency there. So there's a lot of back and forth. So we were doing long distance for a while. And then when I finished up my fellowship, or was finishing up my fellowship, and okay, where am I going to find a job? It was not like a slam dunk for me. Let me go work at Mayo, because I was like, gosh, I'm from the East Coast. I've only ever lived on the East Coast. I'm not too sure about moving to the Midwest. How is that going to work out? So even though my husband had just taken a job like 2 years earlier, we actually did a job search together looking at different possibilities all over the country. But at the end of the day, the thing that kind of maximized both of our career development and happiness was for me to take that position at Mayo. And so that's how we decided that he would stay, I would join. And so after doing long distance for 4 years, that we finally were able to work in the same place together.
I mean, relationships are compromised, right? But for you guys to have to compromise to work and get potentially one of the best hospitals in the world sounds like a pretty good compromise to me.
Exactly.
So you've gone through all these experiences. Throughout it, is there any time that you can look back and say, that was the most challenging time of my career?
That hasn't happened yet. We haven't got there, actually.
All right. Take me to it.
Yeah. So, I mean, this is a really long story, but I will try to boil it down, and then you can ask me questions about individual parts. But essentially, we were on faculty at Mayo for several years and decided to try to build our family. And that was when we found out that I was suffering from infertility, and we had a couple years trying with assistance, and I ultimately had to do IVF. And then our son was born right as COVID pandemic was in full swing. And we realized we didn't really have any help because all of our family is on the East Coast. And ultimately, for a variety of reasons, we decided to move back to the East Coast. So then I was back at Penn for a couple years. And after that, for another variety of reasons, we decided that we moved back to the Midwest. And at that point, we thought we were probably going to both go back to Mayo. There was a definitive job for my husband there, and we thought there would be a position for me as well. And I remember that probably the most challenging day in my career, one of the most challenging days of my life so far, was that day I got the call that was like, there actually isn't a position at Mayo. I was like, well, I've already told the folks at Penn that I'm leaving to go back to the Midwest. And my husband has already taken this job at Mayo. What am I going to do? I was like, I don't want to be not working. So that was probably the most challenging day in my career, I would say. But then I was able to reach out to University of Minnesota. They've been just amazing in so many ways. I was working part-time for them clinically because we live in Rochester where Mayo is. It's too far to commute on a regular basis. So I come up here a week a month and I do clinical work for that week, inpatient consults only, which is, to be honest, my dream clinical job. And it just happened to work out that way. And then more recently, I started as the fellowship program director, which is in education, which is the main thing that I've always loved in medicine beyond clinical medicine. So it's worked out, but there was some really, really challenging weeks and months until we figured things out.
Wow. Yeah, that sounds really hard. You moved your whole life out there and then things don't go as planned, but so is life, huh?
Exactly.
So if we were to look at your career at this point, you have gone to one of the top medical schools in the country, gotten to do a residency at an Ivy League school, and then gotten to work at Mayo Clinic, which is arguably one of the best hospitals in the world. People would look at your resume and say, wow, everything must have been really positive experiences. Everything must run perfectly in these systems because they have such great reputations. Is that the reality?
I mean, I think it doesn't matter whether you're at a community hospital or a big academic center. There's always going to be some things that work amazing and some things that don't. I mean, I think every hospital has specific things that they're really good at. I mean, Mayo happens to be great at most things, but their saying is the needs of the patient come first. And so it's a system that's really set up for that. And so things do work really smoothly for the most part, but there are big waiting lines to get in. It's a very, I would say, expensive system. So not everyone can afford to get their care there. So, I mean, I think there's pros, there's cons. I'm at a system now, which is much less financially well off, maybe. I really like that they have a mission to serve the people in the community and serve the state of Minnesota. And that really resonates with me as somebody who's involved in advocacy work and equity work as well. So that really resonates with me. But I think, again, every institution has things that it does really well. Every institution has things that it has a lot of challenges with.
How many years have you been a doctor for?
Well, I guess that depends. What do you count a doctor? I mean, I graduated with my MD in 2009. So I guess if you count it from technically when can you call yourself a doctor, it would be 16 years. But then there was 3 years of residency, 3 years of fellowship. So how long have I been practicing? After completing all the training, it's about 10 years.
But you've been in the field for at least the 16 years. And in that 16 years, how do you feel about the direction of healthcare and what it's going? Are you worried at all?
Yeah. I mean, I think it's hard to sum it in one word. I think that it's positive and negative. I mean, I think the positives are all of the scientific advances. I mean, look how far we've come. Even in the past, you look at all the history of humanity and it's not much good medical care. We're whacking off people's legs if they got infected. We're using leeches, all this stuff. And then all of a sudden in the past 100 years or so, there's major advances to the point that we've cured uncurable disease. We've cured so many types of cancer. There's such advances in the surgical field. So I think there's so many amazing advances and they are continuing as long as research in this country continues. I think that these advances will continue to be made. So there is a lot of promise. I think what worries me is that there is a huge gap between what could be offered and what people are actually able to make use of. So people that don't have insurance or people that are underinsured or don't have good insurance plans, it doesn't matter that cancer is theoretically curable. It doesn't matter that you can be on medications to prevent complications of diabetes and prevent heart attacks. If you can't afford the medications, you can't access them, it doesn't do you any good whatsoever. So I think that's my worry, that we continue to make all the advances and all the scientists are doing their amazing work, but how do you actually get it to the people that need it? I mean, and if we keep pushing physicians out of small hospital systems, these large hospital systems are just eating up all these smaller hospital systems. So if you can't get to one of the big hospital systems, you don't have the means to do that, or your insurance doesn't cover the system that's close to you, and we cut down on virtual care and all of this, what good does it do that we have all these advances if people can't access them? And the other big threat, I would think, or in my opinion at least, is social media and all these quack curers out there. I mean, there are literally people that are curing their cancers at home with all these quack herbal medicines and then dying of cancer because they're not willing to take actual evidence-based therapy for their disease that could have been curable, and then they let it go until the point where it's metastatic disease and then it's uncurable. And it horrifies me. It angers me. It is just so terrifying, the power of social media to spread all of these rumors about things like ozone therapy and like high dose vitamin C as cures, what ivermectin, all of these things. And it just is, it's killing people. And so that type of misinformation and the fact that social media is allowing it to spread, I think is a huge threat.
It's the perfect, because if I am a person of lower socioeconomic status, I have something going on, I go to my medical system saying, I need help, yet the system can't provide the help in which I need. I am then left in a situation where I'm suffering and looking for solutions. If I'm not getting it from the main system, where am I going to go next? And oftentimes these people are going to social media and finding these alternatives where that seems much more accessible. I could follow this advice and hopefully this will help me. And this pattern is very, very dangerous. And so we need to ask ourselves as a healthcare community is, what do we need to do to expand access to the most innovative care that we are blessed to have here in the United States? And for me, I don't know the answer. But what do you think are some steps that we need to do to help get there?
I mean, I don't think there's one magical cure, but I think that I wouldn't pause research, but I think there needs to be a lot more focus on distribution of already existing solutions rather than just pushing the next best, greatest treatment. So while I think that absolutely there should be funding for cancer research, for diabetes, for heart disease research, it's like, do we really need the fifth and sixth GLP-1 medicine to help folks lose weight? Or should we focus on what can we do policy-wise to lower the cost to get these medicines to the folks who need them? Because honestly, if we help people at an earlier stage for anything, whether it be cancer, whether it be heart disease, whether it be diabetes, if you actually give these relatively what should be cheap treatments early on, you're actually preventing all of those downstream complications that then life-threatening and actually have if you want to think about it just on a cost basis, have so much extra cost for the healthcare system, right? If we focused on getting every woman the mammograms, the colonoscopies, it's like not just women for the colonoscopies, but you know what I'm saying? If we focus on getting the screening and the early treatment, like as soon as everybody should be getting those hemoglobin A1Cs every year or two. Everybody should be getting their cholesterol checked every year or two. And as soon as you find there's something, that should be treated with a medicine, we should provide that to people for free or like very low cost, because I truly believe that if you do that, the downstream cost is going to be mitigated so many-fold, right? So it feels like, oh, how can we afford as a country to give statins to folks? It's like, well, don't think of it as the cost of giving statins to folks. Think of it as how much you're going to save on not having to do cardiac bypass surgery, like coronary artery grafting and stenting and like all of these costly procedures on folks who have heart attacks because they weren't on the medicines to prevent them in the first place. So if we get in there earlier, provide free or low cost medications and screenings to prevent the disease from then getting out of control. Same thing with cancer. If you can get the breast cancer when it's early stage and get it out with a lumpectomy and radiation and maybe, if applicable, hormone therapy. But then if it never becomes metastatic, you never need chemotherapy. You never need all of the immunotherapy. You don't need all of these things. And I mean, is it great that we have scientific researchers that are working on the 5th, 6th, 20th line of all of these therapies for people who have metastatic disease? Sure, but wouldn't it be just as good or even better to try to catch everyone's cancer early on before it gets to that point? I mean, I remember the day that I was like, I'm in Hem-Onc fellowship and I was already liking hematology. I was like, I can't be an oncologist in this country. We get this ASCO post. It's like an update of research, and there's like a page on something in gynecologic cancer, and it's metastatic cervical cancer, survival extended by 3 months with this, and it was like this huge deal. And then there's this teeny little thing at the bottom of the page about how in like rural India, cervical cancer screening by trained midwives had like prevented cervical cancer. And it's just like this dichotomy of like, why is it such a big deal to extend life by 3 months? Shouldn't we be doing what we need to do to prevent people from getting this in the first place? That's rural India, and this is the United States, where the funding is like the sexy treatments for the metastatic cancer. That's it, all these researchers in the lab, and it just really got to me, I think.
This is where I wonder, can we fix this? Because the system is so ingrained in it's going to follow the money. We live in a capitalist system, and now we have the insurer providers. And the idea, when you look at them, you say, oh, well, their job, it makes sense that they should want to save money, because if they save money, they have to pay out less for services. But if you look a little deeper, then you realize that they're actually vertically integrated, meaning that they now own a lot of the PBMs, the pharmacy benefit managers, who you can get a kickback from the more medications that people take. So it's very convoluted, and there's so many moving parts with it that I don't know if there's a solution within the current model that can be fixed. It's going to require some real radical change. And the two changes that I'm seeing is that doctors are leaving medicine and they're starting their own concierge style or longevity medicine, GLP-1 clinics. And I'm like, yeah, that's cool, so they can actually give care to their patients. But if you're all leaving medicine, then what happens to all the people that need it, that can't afford those cash-based services? And that's going to be a big problem. But then we should also look to our counterparts abroad who are on these national systems and seeing what are they doing better than us and what can we learn from them, considering we have the most innovation in the world, yet we don't have the best health outcomes.
And I think you're right. There is not an answer. I mean, I think that are there countries that have almost universal health care? Sure. But does then that make the wait list for things that are not just elective incredibly long? Absolutely. There's countries that say, hey, we need more primary care. And that is very, like, in this country, we absolutely need more primary care. We probably need less of specialty care and more primary care. But, and it's this vicious cycle, because since we don't have primary care, people's disease gets out of control, and then they need the specialty care for their heart disease and diabetes because it wasn't managed early on because there's nobody to manage it. But there are countries that put caps on how many people can go into specialty fields, and then that creates huge shortages when people need them. I mean, I had a friend whose grandma lived in another country and had a stroke, and the only person available to give stroke care was basically a family medicine doctor who had an interest in neurology. I don't think we want to create that model in this country either. We don't want to have limited amounts of the specialists that we need. So it's it's really hard because some of these solutions is not just a one, let's make this regulation that'll fix everything, or let's cut funding for this and increase funding to here. It's almost like you need to blow up the whole system and just start it again. And obviously we can't do that.
I think one of the things, and I'd like to hear your thoughts on this, is that one of the things I'm most excited about, and I think that the direction we have to go in, is when we talk about preventative screening, it has to come from a remote therapeutic monitoring approach where we're doing it remotely to at least get early identifiers and utilizing AI to say, are there certain biomarkers that we can collect someone without them coming into the doctor's appointment that can risk stratify them and hopefully get the higher risk people in faster?
I mean, I think that would be great. I think a lot of this is still, if you have the marker that shows you are at risk of colon cancer, how do we actually get you to get the colonoscopy, right? Because most likely, if we fix that barrier, the problem is still going to be there, right? I don't know if you're ever going to say, hey, this marker shows that you have a low risk of colon cancer, so don't get your colonoscopy. Not sure we can feel super comfortable doing that, but even for those people that are like, you're at high risk, the problem is really getting them in. So unless there's like literally a rolling like colonoscopy machine that can come to their house, right? And do that. I mean, that's actually the barrier, is getting folks in for what they need. And it is very complex. I mean, literally even trying to schedule my own screening stuff. The test has to be available within this close to the doctor's visit in terms of time. Otherwise, the test has passed too much time and you can't see the doctor, and then it becomes negated. And so we have to wait for the doctor's appointment to open up so that then we can schedule your test. And then we don't have anything right now. Keep trying to call. And it becomes this hours long process. And I'm like, okay, I know what the consequences are if I don't get these screening tests that I'm supposed to. So I will keep calling back every day. But a lot of people just don't have the knowledge or the time or the ability to do that. And it's just, the system makes it so difficult.
Yeah. So I want to finish off with two questions. And the first off, there will be other doctors, other healthcare professionals that listen to this, maybe earlier in their career, and they're not really sure where to go from here. What do you want to say to those people?
Yeah, I think that no matter how much we as physicians be negative about the system, I think that absolutely medicine is still a field that has a lot of potential. There's a lot of room for positive growth. And I think if you get through the training, if you get the credentials that you need, if you get the clinical training that you need, then you can become a free agent to do what you need to do what you think is best to improve the system. I think that we're always taught in this very linear model of you go to your med school, you go to your residency, you go to your fellowship, you get the position at the academic hospital, you go assistant professor, associate professor, postdoc. You do not have to have that linear kind of climbing the ladder role. But on the other hand, this is not like a Bill Gates style thing where you can drop out of medical school and still be providing sound medical advice. Don't be that person either. And get the training that you need to get. And I would encourage everybody to do that residency as well, to really get the clinical training. And then absolutely the field is completely open. Go out there, change the field of medicine, and there can be unlimited possibilities available. You can go to DC and become an advocate. You could become a lobbyist, like a highly trained healthcare lobbyist. You could work at a pharmaceutical company and try to restructure their research. Do any of these things. I don't think that we do a good job of encouraging that in medical school, of encouraging kind of the alternative pathways and careers. So it's do what you need to do to get the training that you need, and then make your own mark and what makes you feel that you're contributing to the field.
I love that so much. I agree. We need innovators. We need people that are willing to go and challenge the system. But if you're going to complain without solutions or doing something, then that's for nothing. But if you're going to go and identify problems and go fix it, which luckily is built into the DNA of people that go into medicine. So that's a good thing. Now, shift focus now. You have a young son. You said your son?
I do.
Right?
I do, yeah.
once he is at a point where he's going to need medical care, or maybe already does, or other loved ones who are currently in the system, what do you want to say to them, and how do you guide them of how to handle the current medical model?
Yeah, I mean, it's challenging because I've been a doctor and a patient. I got some serious complications in pregnancy. So I was a serious patient, been a doctor. And I think it is a balance because like we always tell people, be a good advocate for yourself. Like we always want to be our loved ones, doctor's appointments. But I still think as a doctor and as a patient, I encourage people to really have that respect for medicine as well. So don't be the patient that, well, Dr. Google told me X, Y, and Z. These are the folks that I worry about falling victim to the hacks of the ozone and the ivermectin therapies and all of that. It's like the one who's trying to do, what they've been suggested and advocate for themselves, but that's not the way to do it, right? I think it's really important to understand, like if you're not understanding something a doctor's saying, ask for a better explanation. That's something I'm teaching our trainees is let's bring it to a level that somebody who doesn't have any medical knowledge understands. If I go to a financial planner, I need the very, very, very basic. So as physicians, it's our job to provide explanations in the very, very basic format. And if somebody doesn't understand, is not comfortable, feels like the physician is not willing to do that, it's absolutely get a second opinion. But also it's like you don't need to be diagnosing yourself, managing yourselves, demanding all of these things, like really not appropriate to be like messaging back and forth on the online platform with the doctor. Like it's not supposed to be a texting type of situation. So I think it's understand the system, respect the system, but also self-advocate by getting that education that you need and always looking for better explanations.
That is great advice. And I agree. It's a big reason why I started my company, MedStory, is to be like, let's teach these providers how to educate on a way that people can understand without getting lost in the jargon, which so many people do, unfortunately.
Yeah.
We have a little bit of time. Is that a story within the pregnancy and the health complications? Is that something you feel comfortable sharing?
Yeah, I mean, that whole journey actually has really informed a lot of my career moving forward. So like many women in medicine, I waited until after training to start building a family. And then like 25% of women physicians, I found that I was dealing with infertility. So almost double the amount of women physicians compared to women in the general population will have fertility challenges. And so that was really eye-opening. And then finding that so many of my colleagues had also been through IVF or had fertility challenges as well, that opened up a lot of, I think, introspection and advocacy work for me. So I've actually now dedicated a big portion of my career to advocating for better fertility awareness and policies and education in the physician community. So I feel that we should be educating all medical students about risks of fertility. I work with a couple of nonprofit organizations where we really focus on fertility education and awareness. I've written op-eds. I co-chair a group at the American Medical Women's Association about fertility. So I think it's really opened my eyes to how common this is. I think it's really opened my eyes to how egg freeze. I thought about it, didn't even cross my mind. Even though, wait, you're going to be 40 when you try to start a family, but is that not going to be a problem? If nobody tells you about that, it's just not, you're just trying to like get through the basics and get the medical degree. It's not on the radar for a lot of people. So that really opened my mind. But then having not only the IVF and the fertility challenges, but then I had complications. So I basically got postpartum preeclampsia. So instead of getting it before delivering, where you basically get high blood pressure and protein in the urine and you can get organ damage, but then the treatment is delivery. So I unfortunately developed this after delivering my son a couple of days, and you can't really deliver. So there really is no treatment. You just have to be supportive. But it just really opened my eyes to the system and how everybody in the system is doing their best, but it's not, parts of the system are not talking to one another. Like I'll give two examples. One of them is just definition of preeclampsia, high blood pressure. So what are they doing? They're monitoring your blood pressure every few hours, and then they're adjusting your medications based on it. But the time that they take your blood pressure has nothing to do with the time that the team rounds and the time that they... So I would be like, wait a second, I know that this medication is dosed twice a day at 9 a.m. You're taking my blood pressure at 7 a.m. Still super high. Something needs to be changed. But if they're not putting in orders until after their rounds and it's 11 a.m., they'll have missed that 9 a.m. dose. So I'm going to be the annoying patient, call a nurse and say, would you mind telling the team, seeing if they can adjust something? If I hadn't had the medical knowledge to know that that's how the system works, I don't think I would have had the same care. But I also felt like I was being the annoying patient who's trying to take advantage of things. And so nursing is doing their best to take the blood pressure. The team has 1 million patients. Nobody is doing anything wrong. It's just that the system is not built to make sense in a way that ties everything together. The other story that just really cracks me up in terms of we don't really have any awareness of women's health is that part of the workup of protein you get protein in the urine with preeclampsia. I had protein in the urine. And part of the workup for that is let's do a urinalysis. And we're really concerned because we saw some blood in the urine. And I remember this male physician, and I was like, we're really concerned about this blood in the urine, and we might have to do a kidney biopsy. And I looked straight at him and was like, well, when you collected the urine, you told me to just pee into this cup. And I just gave birth, right? So I think that's probably not from the urine. I think it's from everywhere else. And I said it in a nice way, but it was just like, oh, right? People are just taught to read the test results. They looked at the urine, there's blood in the urine. They're not considering the larger picture. And I do think it's a funny example, but not really. In the way that we teach medicine, it's very siloed and isolated if you just look at a test result without looking at the bigger picture. And so I just remember that as hopefully now moving forward, this guy will realize that, okay, women just gave birth. Let's look at the bigger picture here.
Totally. I think it's easy when you're just grinding nonstop, seeing so many patients. It's okay, what's the quickest way I need to do? What's the next action step? And instead of taking a second, take a step back and be like, okay, maybe we can make some better decisions. So I totally hear you there. Wow, this is amazing. I think that we're definitely going to be able to put together a really nice story from this. The life experiences that you've had and the fact that you've gone through them and then really push for advocacy. I have so much respect for you for doing that. I know it's not easy, the work that you do. And so all I can do is just hope that you continue to do it because we need more people like you in the field.
Oh, thank you so much. And I think the last thing I'll say, if you ask for advice or anything for kind of young physicians, is why do I do this advocacy work? I feel that maybe it's a little tongue-in-cheek, but my kind of way of thinking about things is you follow the rules as long as you need to until you can become the person that can change them. And I want to be the person that can change the rules that don't make sense right now.
I love that so much. Heck yeah. That's hard for people to do. People love to follow the rules, but I love that. I'm going to steal that one from you if that's okay. Thanks for listening to the MedStory podcast, where we share the stories of the greatest minds in science and medicine. I'm your host, Spencer Locke, with a special thanks to our executive producer, Shina May. Our music comes from Blue Dot Sessions and the Descript Audio Library. The MedStory podcast is made possible by MedStory Studios and listeners like you. So if you'd like to support us, please leave a review. It means more than you know. And if you have a story to share or want to produce a podcast of your own, reach out to us at info@medstorymedia.com. We'll see you in the next episode.